Welcome to this series of lectures in oral medicine, this one entitled Diseases of the Oral Mucosa and Malignant Disease. In this lecture we'll be talking about non-infective stomatitis, and for this lecture we will follow the following headings of traumatic ulceration, fictitious ulceration, self-limited inflicted oral lesions, recurrent aphthous stomatitis including Behçet's and HIV related, dermatoses such as oral lichen planus and lupus erythematosus, allergy and eosinophilic granuloma. The lecture will give a broad overview, and it is expected that some of these conditions that you will do some further reading to gain a bit more of an understanding. Traumatic ulceration is often due to a sharp tooth or a broken tooth, or the cause of the ulceration is apparent from the history. So it is important to take a very good clinical history as to the type of ulcer, how long it's been there, whether anything has been done for it, and so on. Usually if it is the offending object or sharp tooth is apparent, then if you improve the sharpness by smoothing it off or restoring the tooth and then reviewing the ulcer in 2 weeks' time for improvement. If there isn't any further improvement, then you may need to look at further treatment management such as a biopsy. Fictitious ulceration or self-inflicted oral lesions, usually they lack correspondence with any recognizable disease. They often may have a bizarre configuration with a sharp and not regular outline, and usually otherwise in a healthy mouth. Clinical features are usually inconsistent with the history, and the ulcers are usually in an area that is accessible to the patient. In this slide we have two clinical photographs, one showing oral lichen planus, where this lady's tongue is both erythematous and atrophic, showing a pattern that's sometimes seen in lichen planus. In this other clinical photograph you see a patient with a upper gingival erythema which is generalized, and that could be a typical pattern that you see in a person that's got a contact allergy. In this clinical photograph we have a patient with a chemical burn, such as if an aspirin was held in that area, and the acidic nature of aspirin will burn the mucosa to that clinical appearance. Lichenoid reaction, which is again a drug related or medication related lichen planus appearance in the mouth. And erythema multiforme, which in this case shows a typical blood crusted lips with generalized ulceration of the lips and mouth. Recurrent aphthous stomatitis can often present in three ways clinically. The minor variety, which is a regular ovoid ulcer with a yellow-white fibrinous exudate with a halo, erythematous halo surrounding the ulcer. This is typical of the clinical appearance of both minor and major recurrent aphthous stomatitis. The minor variety usually heal within 2 weeks, usually less than 1 centimetre in diameter, whereas the major variety are much larger and often cause more pain and can take up to 4 to 5 weeks to heal, and usually with scarring. In contrast, herpetiform recurrent aphthous stomatitis, the name herpetiform is because it appears like herpes viral infection, but it is not a viral infection. It's a recurrent aphthous stomatitis. They are usually 1 to 2 millimeters in diameter, multiple ulcers which can coalesce to form much larger ulceration. Behçet syndrome involves oral recurrent aphthous stomatitis ocular lesions and genital lesions. And often if these are apparent clinically through history, then a referral may need to be made to an immunologist. HIV can also present with recurrent aphthous-type ulceration, and often these are much more difficult to manage and are a little bit more painful and last longer. Deficiency states such as in alcoholism, where you may get vitamin deficiency due to poor diet, may also lead to ulceration, as seen here in this clinical photograph. Ulceration can also be due to oral mucosal squamous cell carcinoma, and in this case here on the lip you can see a typical ulcer that on biopsy would be squamous cell carcinoma. Here on the lower right buccal ridge interretromolar area is a squamous cell carcinoma, and on the lateral tongue of this patient, which is quite indurated and extensive. Piostomatitis vegitans is a condition which you may see in ulcerative colitis, and clinically it presents with these erythematous gingiva with some white yellow pustules. Further investigation and history may need to be taken in this situation. Other vesicular bullous lesions that can also cause generalized ulceration in the mouth: pemphigus vulgaris, pemphigus where you get the epithelial cells coming apart and therefore you get bulla formation and ulceration; pemphigoid, where it's the epithelial layer that lifts away from the underlying connective tissue, and again that can have a similar desquamative gingivitis effect or generalized oral ulceration. Erythema multiforme typically causes generalized ulceration in the mouth. On the skin it may cause these typical target lesions. Oral lichen planus can also be caused by medication. There are various types of medication, antimalarials, anti-diabetic medications, to name a few, and lichen planus may present in many clinical forms. Here you see a typical plaque form, oral papular form of oral lichen planus, or a desquamative gingivitis, which is one presentation that you may see clinically for lichen planus. So in summary, what I have put here is a flow diagram from Corson and Adele, which indicates to you how to handle a recurrent ulcer from a clinical perspective, and if you follow the instructions there, it gives you instructions on the different clinical presentations and how to go about investigating. And in this flow diagram, again from Corson and Adele, you get lichen planus-like or white striated lesions without atrophic areas or erosions, and if you follow the flow diagram, it gives you a reasonably good indication of how to handle these patients clinically. You can also log on to oralmednet.com, that is oralmednet.com, and register free, and at that site you will also get some clinical information and oral medicine information sheets that would be useful for you both clinically and for exam purposes, and read through them as another resource. Here, again from Corson and Adele, persistent ulcers, and if you go through the flow diagram, you can see that some of them are traumatic ulcers, which no further treatment may be required, to something more sinister such as carcinoma, which would require biopsy and then referral further, as well as other autoimmune diseases that cause ulceration and how that can be managed. If we now move on to tongue disorders, I've listed here some conditions that may typically present to you in the clinic, especially that of the sore tongue. A sore tongue can be due to ulceration, which would be obvious, a glossitis, which would present as an erythematous atrophic clinical picture. But a sore tongue in a otherwise physically normal mouth and physically normal appearing tongue could be due to a hematinic deficiency, mild, or a neuropathic problem, such as in burning mouth syndrome. Erythema migrans, also called migratory glossitis, or geographic tongue in the layman's terms. These are usually not symptomatic, but in some people they can be symptomatic and cause burning. Some normal anatomical features, such as foliate papillae, if they're prominent, they are usually just bilateral pinkish or soft nodules on the lateral posterior border of the tongue. If these are prominent or appear red, they can be alarming to someone who hasn't seen these papillae before, but usually if they're bilateral, then that would give you an indication. Lingual varicosities, which are dilated tortuous veins which often occur on the ventral surface of the tongue. Usually they are bilateral, so therefore that gives you a clue as to what you're dealing with, and usually these become more prominent with age. Hairy tongue is usually caused by elongation of filiform papillae, and discoloration is due to pigment producing bacteria and fungi, but not candida. Candida is associated with medium rhomboid glossitis, which is a rhomboid-shaped erythematous lesion on the dorsum of the tongue in the midline. Macroglossia, or enlarged tongue, can occur in in a person that's got congenital hemangioma, in Down syndrome patients, cretinism, acromegaly, amyloidosis, where amyloid deposits may be occur in the tongue, creating a macroglossia, and lingual thyroid. Some of these things, especially acromegaly and amyloidosis, will be covered in later lectures. So this has given you an overview of some of the non-infective stomatitis conditions in the mouth. There will be other lectures that will feed into some of these conditions, and where you don't get other lectures or other information from lectures on those conditions, then some background reading will